Well, thank you everybody for joining us today. We're going to start with a question that I will put in the chat and ask each one of you to respond to. Everyone is on mute. So if you could respond to the chat, we have a question we'd like you to answer on a scale of 1 to 10, with 1 being great and 10 being awful. How are you feeling this September compared to September 2020? And what we're going to do, if everyone will participate and put your number in, and I see, thank you for those who are already doing that. While we're doing the opening part of the webinar, we'll have somebody looking at the numbers you've put in and will reflect kind of the group score to you, but we'll also be able to share when this exercise has been done with early care professionals, what their response is and what we're kind of learning by asking this question of what's going on with them. So thank you for responding. And you can continue doing that. And I'm going to go ahead and kick us off. So I am Marlo Nash. I'm your moderator today. I'm very happy to be with you. I come to you as a longtime early childhood advocate and systems change strategist. I've worked at state and national levels with public and private partners to improve the life and outcomes for young children and their families. It's what brings me to this work. And I'm very passionate about it. And I more recently, a few years ago, became connected with the Campaign for Trauma-Informed Policy and Practice, who's the host for today's webinar. And the CTIPP, I'll refer to it as CTIPP, as I think others will as we get into the presentation, is a national nonprofit organization that's working to bring neuroscience, epigenetic, adverse childhood experience, and resilience research to policies at all levels of government and to practices in all settings. We have a number of projects underway as CTIPP, one of which is the National Trauma Campaign, which is our effort to open up channels of communication between constituents and members of Congress. And we hope that folks will join us for the National Trauma Campaign. Another one is the project that brings us together today. So we've joined for to learn about supporting mental well-being in childcare settings. And today we'll cover the need for that, some case examples of how that's already been going on in different places around the country, and talk to you about a plug and play framework that CTIPP has developed to help ease the process of making not just your childcare settings, but all early care settings trauma-informed, healing-centered, and equipped to build resilience. We're happy to have you here today as we focus on the very important work of addressing mental health needs of all adults in the child care, and even more broadly, the early childhood ecosystems and the children in their care. The purpose of today's webinar is to equip public and private stakeholders with a framework that will help all adults in the childcare ecosystem and other early care settings recognize and respond to trauma as a population level, respond to trauma as from the effects of the COVID-19 pandemic as a population level traumatic event. The main takeaways for today are that there are approaches states, localities, and settings could adopt that will help reduce the impact of trauma on young children and the adults in their lives. That these approaches can complement other mental well-being efforts such as social emotional learning and infant and early childhood mental health consultation, but that we see this approach as something different and additive to those, but a distinct component that's necessary. And that this plug and play framework we're sharing with you today and the approaches that it endorses can be paid for using federal pandemic rescue funding. And it's just a way to kind of set the context for today's conversation. We started on this project when we saw that the American Rescue Plan Act that was passed last March at the federal level has many resources for addressing mental health needs. We focused in on early childhood settings because the child care development block grant and the Child Care Stabilization Fund that are part of the American Rescue Plan Act specifically stated that the money could be spent to address the mental health needs of child care providers and the children in their care. We also know that people define mental health quite frequently as being about counseling and treatment and other interventions. And there's not as much of a shared mental model or mindset across our country about the need for being prepared to address mental health issues as they show up in the moment, as they're happening in real time. So we believe that this plug and play framework is, the purpose of it is to help equip adults in early care settings to be able to do just that, to recognize and respond to behavior that are coming out of having experienced a traumatic event. So early in our journey, we reached out to the Federal Office of Early Childhood Development to talk to them about what kind of guidance was going to go out across the country around using those child care funds that were in the American Rescue Plan Act. And our purpose was to uplift to them the importance of having trauma-informed and healing-centered settings. And what they said to us at that time was that because childcare leaders across the country are not only doing the original job they were hired for, but they are now also tasked with rescuing the childcare industry as a really important part of our economy. So because of that, they said that they agreed that what we were talking about was very important, but they also said because things are so busy and happening so fast, that to have a plug and play framework that really lays out how you can make systems trauma-informed and healing-centered would be a really helpful development. So we set out to create that plug and play framework, which is what we're going to be sharing with you today. And we did that as a volunteer effort, and the framework is free for you to use and access. And we'll talk a little bit more about that. But we wanted to make it an easy pathway for systems leaders, stakeholders, and providers to develop research-informed approach to equipping all adults in the ecosystem to be able to recognize and respond to trauma. It's no secret that we have all experienced a population-level traumatic event in the pandemic. And we know that people respond to traumatic events in different ways. Some are more deeply affected than others. To recognize trauma, it's important to know that sometimes there are low-level signs in adults, maybe an adult who loses their cool or overreacts to small disruptions, feeling disorganized, forgetting their thought in the middle of thinking it. Then there are times when behavior resulting from trauma goes even deeper. Chronic sleep loss, eating more than usual, use of alcohol and drugs, can't hold on to a job, becoming hypervigilant. And in young children, that low level might look like difficulty getting along with others or throwing tantrums, being difficult to soothe. Small things upset them in big ways. But when we see that go deeper, we see children who are disengaged, not participating in play, maybe harming other children or even adults, or being just very disruptive to what's going on around them. So the point of this framework is to help people know what trauma looks like and know ways to respond to it as it's happening. Because we believe children and adults don't need to be left, shouldn't be left to stew in their trauma until it escalates to a point that they have to have a major intervention. We are certainly supportive of having counseling, consultation, and other types of interventions widely available, but we also know that there are things that can be done in the moment, even if more help is needed at a future point in time. And over the last few weeks, we've gotten even more convinced that this work is absolutely vital. Recently, there was a study, a National Institutes of Health study that indicates that infants and toddlers may have a significant loss in IQ. They measured verbal, motor, and cognitive skills and found that the scores across the group that they did the research on fell below the lowest level of the normal range. So the normal IQ range is 85 to 115, and the children in the group were coming in at 78, which is very, very alarming. They are so alarmed that they are reaching out to their colleagues before they publish the study in a journal, because they're saying, please tell us if there's something we missed, because this is so alarming. So they and we are all hopeful that there's something that they find and that this is not true, but actually what they said is because we know what is always true, that maternal anxiety, depression, poverty, the kinds of things that we know cause disrupt early childhood development, were all present, and then the pandemic exacerbated all of those things. That it's very likely that something is going on. And of course, what we know is there's no time to wait and see what they find out down the road. If we've got to assume it's true and jump in as really a state of emergency and get to these young children as quickly as possible to help them recover, because that's the good news. Their loss can be mitigated, but it's going to take efforts, and we think this framework is part of that effort. We also, just another new development, this was just a few days ago, Head Start at the national level issued an information memorandum to all of Head Starts across the country to say that it really is very important for them to be thinking about how to address the trauma their staff experienced. Well, they talked about addressing the mental health needs of their staff. And what we understand from the research is that trauma is very likely part of that, and that this framework could be a way to operationalize that information memorandum that the federal government sent out. I think that the last thing I'll say before I introduce our speakers and kick off the part of the webinar where we'll show the framework and share some other findings with you, is just that when it comes to the American Rescue Plan Act funds, there is lots of money in your states, at your county levels, in many of your cities and even smaller communities that could be spent on doing the kinds of things we're going to be talking to you about today. What's important to recognize about it, though, is it's each of those decision makers over those different financing streams that come through the American Rescue Plan have to be convinced to make the decision to spend money on addressing trauma. So there's definitely an advocacy component to this that I want to just really impress upon you, because the money's there, but it's not going to just flow toward this kind of activity without people like you stepping up and really helping make the case for the need. And that's another reason we've developed this plug and play framework, because we feel like it equips you with a concrete thing to ask for. And we'll talk more about this, but as part of developing it, we will be including a list of vendors who you could contract with to do the different parts of the framework, and also some cost modeling, so you would be equipped to know how much to ask for to implement it in your state. So I'll wrap back around and say we started with really thinking about child care settings, but we believe that this framework is useful across other early care settings, and you will hear that as we talk about some of the case examples today. So bear with me a moment while I share my screen again. So I will introduce our presenters more fully as we get to each one of them in the flow of the program today, but just want to kind of, by way of letting you know who's with us today, to share information with you, and also to talk to you a little bit about how the webinar will flow. So we have Suzanne O'Connor, who's a senior advocate for trauma-informed care at United Way of Philadelphia and Southern New Jersey, and a CTIPP board member. And Suzanne and I have been really working together to offer leadership to this project, working with a number of other partners who have contributed. Doctors Caitlin Mulcahy and Jerry Costa are here from the Center for Autism and Early Childhood Mental Health, which is at Montclair State University in New Jersey. Jillian Adler and Dr. Amy Lynch are going to be joining us at about an hour into the program, so they will be able to talk with you later about what some of the things that they are working on in Philadelphia. And we will have Suzanne and Caitlin and Jerry will all present, and then we will have time for Q&A. And what I want to encourage you to do is chat your questions as you have them. We'd love to have a full chat box of questions by the time we get to that Q&A portion. So, Suzanne, I'm going to kick it over to you now to, if you'll do a little more introduction of yourself and your work. And I'd love for you, based on some conversations we have, to start by sharing your own journey about on what led you to helping to lead and fund the implementation of really this framework as a pilot in Philadelphia.
Great. Thank you, Marlo. And I might need you to advance my slides. I got kicked off of my internet on my laptop and now I'm on my phone, but I have everything together. Okay. So just in case you don't see me. So hi, everybody. Thank you so much for being with us. There's a lot to share right now, so much going on, but I think it just helps to give a little bit of context about why CTIPP is coming and having the response that we're having around supporting this work. So I'm a pre-K teacher by trade. The picture on this slide is the YWCA of Germantown. And it's there where I got exposed to trauma training and all of the content that goes with it. I had a parenting grant and then got some quality improvement opportunities with our local United Way and the Success by Six program. And actually in 2004 made the transition from being a director to now, being able to work in a quality rating system and help centers get from, in our case, at our United Way was a star 2 to a star 3 with our Keystone Stars. So our United Way put a lot of investment in quality childcare. But when program managing that work, I was still getting reports of children getting expelled from school, that teachers and parents were difficult and challenging. And I was able, it was 2009, to make a really big pivot and kind of leave that childcare work and spend time trying to understand the early childhood mental health landscape. How do children get services? As a director, I had to expel a child. I couldn't find any services, but I know in Pennsylvania, legally, we are allowed to ask children to leave. And that preschool expulsion just stuck with me. I couldn't figure out what was going on. But then got exposed, and started studying the world of trauma-informed care and family systems, and everything fell into place, what was happening for children. We all have this instinct, if you're in childcare, like something's going on for this child. But what's new is now we know exactly what's going on for children that are stressed and experiencing trauma. And so at United Way, the last 10 years, we've been investing in trauma-informed care as a region, specifically with early childhood providers, providing them access to training. But really, it's very hard. Trauma-informed care and all the science has come out, but it's not been very specific around what exactly to do. So that's kind of the journey. I come at this work very convinced that trauma-informed care can really help us, especially now during the pandemic. So all of this years of kind of capacity building, creating some tools, we were able to do some research on training that we funded to be able to then share with all of you, what it is that we know will work, does work. And so if you can go to the next slide. Great. So all of that, we were doing this trauma-informed care work all along, but of course the pandemic certainly has brought a bigger focus to this issue. And what we know now, what's going on is that the childcare workforce is disproportionately impacted by COVID deaths and hospitalizations. There was a recent research article in JAMA Pediatrics. And so that is a fact. Both staff and children in childcare are at risk for developing post-traumatic stress and post-traumatic stress disorder if we don't do anything to intervene. And post-traumatic stress is a typical reaction to what's going on, but if it lasts more than 3 months, now you're kind of getting into post-traumatic stress disorder, which really requires some interventions. And then just like Marlo stated, children are at greater risk to miss developmental tasks. And so there's many reasons we need to do this, but like I said, now is the time, given everything that's happening. Next slide. Okay. And so what we've talked to a lot of people, and we feel like the three buckets, the recommendations that we'd like to make for use of spending this recovery, this amazing opportunity to spend some of this funding, is to create trauma-informed childcare settings. And I'm going to spend a little bit more time there a little bit later. The second recommendation is to assure that children and parents have access to trauma-informed mental health supports. And what this means is there a seamless early childhood mental health system. When I was at United Way, we did a survey, and we were curious about the kinds of traumas that happened to staff and to children, the death of a teacher, to a shooting outside the childcare center. And as United Way, when our centers would call us, I didn't have any solutions for that. I couldn't help but know that there are different sectors out there that we could come together and come up with a way to help childcare centers deal with extreme challenging behaviors, interventions, as well as when there's a crisis, and how do we de-escalate and debrief those. You know, when these things happen to schools, when there's a crisis at a school, I hear that, therapists go to school and we triage, and there seems to be care, and is very organized for the public school system. But when it comes to childcare centers, there really isn't any resources to get help. Next slide. Oh, great. I just mentioned, so I apologize. I have 3 screens here and my phone's about to die. I was not expecting my last IT glitch there, but I forgot to mention that the one thing that we also recommend using funds for is to address the mental health issues of staff around grief and loss, and providing funding for therapy. And our presenters later on are going to talk a little bit about that as well. So those are the 3 recommendations. And so what is trauma-informed care, and how does it address mental health and well-being? And I know trauma is a word that people don't like to use with this work. Sometimes we use resilience or healing centered. So I just wanted to acknowledge that people call it different things. But for this conversation, we're just going to call it trauma, because that's the language that's in the mental health world right now. And so what we've been able to do in this space is talk about trauma in terms of it being neuroscience, NEAR. So I have the definition here that it's really about understanding neuroscience, epigenetics, ACEs, which is the Adverse Childhood Experiences Study, as well as resilience. And so there has been a lot of work already in the early childhood space around social emotional learning and resilience. So we're already, we're not halfway there, but we really have laid the groundwork to now enhance what we're doing with some more information and skills. And so when you put all of these fields together, it gives a better holistic picture of a person's wellness and trauma history. I also have something on here for early childhood people that might not know SAMHSA. That was a term that I had to learn when I was coming from early childhood, understanding social services. It stands for Substance Abuse and Mental Health Services Administration, and they have put out a lot of best practices and principles, and many of the trauma models and frameworks that you see refer to SAMHSA. So that really is, the North Star when it comes to guiding our work around implementing trauma-informed care. Let's just make sure. I will say that the principles that we look to integrate with trauma-informed care and translate for you are around safety. So these are the 6 principles SAMHSA has put forth: safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment and choice, and cultural, historical, and gender issues. So you can see how these principles can cover a lot of territory when it comes to implementing policies and practices around trauma-informed care. And ultimately, I don't know if you pay attention to Oprah or folks on this call, I'm sure some of them know Dr. Bruce Perry, who's a real leading clinician and has a great assessment tool for trauma. Together, Bruce and Oprah wrote a book called What Happened to You? And that really is like the bedrock of trauma-informed care. It's not what's wrong with you. Why are you pushing my buttons? Why are you doing these things? It's what happened to you. What's causing your stress. And so that's really the fundamental shift in our mental model. It's not what's wrong, it's what happened. Next slide. And to my great surprise, because I've been busy implementing a lot of programs at United Way, there has been a lot of work around integrating trauma this into early childhood settings already. This image probably looks familiar to a lot of you. And what I like about it is that it's a public health triangle, and it translates well across all sectors. So I think anybody in sectors can understand what we're talking about when you think about prevention at the bottom, kind of those targeted supports at the second level, and then more of your clinical interventions at the top. And the whole idea around this is that the more you do on the bottom part of that pyramid, the less we'll have at the top. So if we're able to do some universal precautions, if we're able to do some more intentional targeted supports, which I think all children need, this was probably intended for small groups, but we should be doing these targeted supports for all children, because trauma and the science tells us that everybody's been impacted. So everybody should have a right to this treatment. And the work that the pyramid model has done is, you can see at the top, there's individualized interventions. And again, what are those? How do we access those? In the second tier, you can see children who have experienced trauma might need help with regulating their emotions and learning skills to cope with their feelings. But what you'll hear from Dr. Amy Lynch is there's a lot more to helping regulate kids than feelings. It has a lot to do with sensory development. And I think that's what we're seeing in a lot of children. We know that those are high peak windows for development, those early years. And sensory development is, I think, one of the great tools that early childhood providers can borrow from. It's a great field to learn what kind of interventions can help, because trauma is stored in the senses. Especially young children don't even have language for what's going on with them. And then, of course, we need a workforce that's present, and that's very difficult right now. Last night on the world news with David Muir, there was a situation with a teacher that was obviously overstressed, and she acted out. And a teacher was just standing there watching her. There were other children in the room. So this teacher wellness is a really big step for early childhood, with a focus on their well-being, because if the teachers are well, the children will be well. Same with parents. Parents are well, the kids will be well. And just this week, Head Start put out a bulletin around focusing on teacher wellness. And so even Head Start, I hope there's some Head Start folks on here, as well as our community providers and other publicly funded programs. This is all of us now. We're all saying the same things are needed. A lot of us have been working on this for a long time and knew it, but COVID certainly has put a spotlight on what we need to do. And so that's the pyramid model. And so again, what we're proposing isn't anything new, but I think what we have to offer is some more guidance and practical application of trauma-informed care, borrowing from the sanctuary model and other models, and translating, because mostly trauma-informed care up until this point has been in the mental health field. I've seen guidance provided in the homeless shelter system, as well as child welfare, but nothing very specific for early childhood yet. And so that's what we're hoping to bring to you. Next slide. So then what changes as a result of this? Staff recognize how to own their traumas. They'll understand overreactions, and we'll be able to talk to one another as staff with some language understanding that does happen. Staff ask what's happened to you instead of what's wrong. Staff understand that children impacted by trauma need more sensory development support. And this is one of my favorite, we get to be creative in this. This is a very new field, but when we think about sensory development in early childhood classrooms, we have all the materials there to enhance this for children. Staff understand that challenging behavior is a sign of dysregulation and uses sensory activities to help regulate children. But also trauma-informed care is also about self. And when I talk about the model and advanced training, it does include some reflection on your own self and what you bring, and understanding that mirror neurons and the fact that we are co-regulating with children. If we're calm and we come off calm, even with our friends and colleagues, you'll have a much better interaction. And then what's also really important is that staff know to help coworkers recognize signs of secondary trauma. This is a very real thing that can happen. You can bring home, it's different than burnout because you're actually having physical symptoms, nightmares, flashbacks. You're actually absorbing and taking in the trauma of the children and families that you serve. So that's some things that will change as a result of becoming trauma informed. And then, kind of at a bigger level, like a macro level, the next slide, please. What we can see is a reduction in preschool expulsion, because we will know how to prevent and support children and recognize that it just isn't a child just being bad, or, Sandy Bloom talks about, we're either labeled sick or bad, when really it's a wound and what's happened to us. And so with that mindset, we can see kind of being more proactive in reducing preschool expulsion. There's also emerging science around that there's greater staff satisfaction, which means staff retention, and more research will be coming out around that. If teachers feel safe, that their calling is being respected and it's a healthy environment, even if given the chance to go, they stay. I feel the childcare workforce is a very important special workforce. Not everybody can be with children. And so this is really important that we can hone in on this, especially now with trying to rebuild our workforce. The other thing that'll come out of it is that there'll be more efficient and effective engagement with other early mental health systems, including infant, toddler, early childhood mental health consultants and that system. I think there's a lot of synergy that could happen there. We'll see stronger family engagement practices, children meeting developmental tasks, and of course, less burden on the EI system. We rely on them for everything, mostly behavior. That's what we do. We call them when a child is having bad behavior, and we get assessments, and that's not maybe the best way to use the early intervention system. There has to be other ways that we kind of triage and address symptoms of trauma. And then something else, a lot of what we see in classrooms that we think is ADHD is a reaction to trauma, but also some sensory processing disorders as well. So, like we say in early childhood, if we can intervene now, we prevent a lot of problems down the road, and trauma-informed care is really the way to get at all of these. Let me just make sure. Okay, and then the next slide. And so this is what Marlo was talking to when we were proposing kind of like a plug and play. So what do you do about this? It's so big. I also want to recognize that there are a lot of people on this call that are already doing pieces of this work. And so this is kind of trying to pull it together and put people on a pathway to, because it seems so big, and how do we break it down, especially now? People don't have capacity to sit in trainings. And so what we've done here is kind of chunk it out into two parts. And so the first part is becoming trauma aware. And trauma awareness can happen in a 2 to 3 hour training. And that's something everybody can do. We think everybody in every organization serving children and families should be trauma aware. And that's where you're learning just basics around the neuroscience that I talked about, fundamental awareness that behaviors are associated, these challenging behaviors are associated with unresolved trauma. And again, common language is really important. And so trauma awareness is something we can all do, even before getting into anything sophisticated. If everybody just has the language and the awareness, that would be a big gain for our sector. And so from there, when you do trauma awareness training, and folks on the call who do this work know that there are people that get very excited and inspired by it. And those become your champions and your early adopters. And those are the folks that we would recommend move on to advanced training. And with advanced training, some of the things that happen or that you'll learn in advanced training are, hold on just a second, just to make sure, is more skill building, more understanding about brain development, relational health. That's really important, and a deeper dive into that, as well as the self. And so there are some people for whom advanced training is not helpful right now, given the prevalence of trauma that when you go to do deeper dives into yourself, especially in a small group with reflective training, you will be looking at yourself, and not everybody's ready for that. So I just want to let people know, in terms of kind of mandating some of these things, that the advanced training is really a self-selected group. The other part of becoming trauma informed is a checklist, an assessment to know in your learning domains and how that intersects with those implementation, the principles that I mentioned from SAMHSA. And then the third part of this is around the implementation and coaching. This wasn't a linear process, because I'll tell you what, even from trauma awareness, you can already make some changes. You'll already get some ideas. And after your first class from advanced training, you'll already be putting things into practice. So you'll be implementing, but it's probably more of the, maybe some policies you want to change, some classroom management. And so those are the two kind of phases of becoming trauma informed. Everybody's trauma aware. And then there's a process that could take a year and a half. Advanced training is maybe 20 to 30 to 40 hours. And a lot of states have trauma training. So you don't have to go out and shop for something new. But I think what will be new is having an assessment or a checklist, kind of a North Star, so you know what kind of implementation practices and policies can take place and how we can coach around them. And so that's really the process around becoming trauma informed. And then, so I'm going to stop there, and we're going to be transitioning to our next speakers, but we're going to be providing some more information around the toolkit and its content. And so that's something that is going to be coming out, because we realize this is really high level. But I also know everybody on this call is overwhelmed. My plug and play slide before was a big graph. And I just don't think we have a lot of time to take all of those details in. But if you can just kind of chunk out that there is an awareness training that everybody should have, and then there's a more advanced phase for really kind of getting into implementation, that those are kind of the two takeaways for today from this plug and play.
And I think, Suzanne, thank you for that. I'm sorry, did I interrupt you?
No, go right ahead.
Okay, well, I was just going to say thank you for that. And I so appreciate that. I've been watching the process of you really thinking through the pilot that you are part of in Philadelphia, and lifting that up to learnings that can be shared with everyone. And I just want to emphasize kind of the last point you were making. There's quite a bit of detail in underneath the components you're seeing right now on your screen. we very much hope that you will take advantage of the lots of work that's been done to make this plug and play, to ease this process, because there's no reason for you to redo all of that and take all the time, because it took us effort to get this is the high level of a much deeper model that we can, well, you'll have opportunities to dig into with us in the future. But now we are going to transition to our next speakers. I want to remind everybody that if you have questions for Suzanne, go ahead and chat them now, because what we'll do after Jerry and Caitlin speak is have kind of all three of them on a panel, and we'll be able to have questions for all three of them. But I am very excited to introduce our next speakers, because they are a case example of this framework that you see on your screen in place. And they were instrumental in New Jersey in helping the stakeholders understand after Superstorm Sandy that they had a population level traumatic event, and it required a broad scale multi-system response, which is what we're saying to you now. We have all had a population level experience, traumatic experience, and it requires a broad scale multi-system response, especially for young children. So I'm delighted to introduce Dr. Jerry Costa as the founding director for the Center for Autism and Early Childhood Mental Health at Montclair State University. Jerry specialized in infant and early childhood mental health and developmental disabilities in clinical practice, teaching, and policy for over 40 years. He received his master's and doctoral degrees in developmental psychology from Temple University. He's a licensed psychologist and endorsed infant mental health clinical mentor and training leader with the Interdisciplinary Council on Development and Learning. And he's joined by the Associate Director of the Center for Autism and Early Childhood Mental Health at Montclair State University, Dr. Caitlin Mulcahy, who is informed by over 20 years of work experiences as an infant, early childhood, and family therapist within the sectors of child protection, early intervention, and community mental health. She received her master's degree in counseling psychology from Boston College and a doctorate in family science and human development from Montclair State University. She's a licensed professional counselor and is an endorsed infant mental health clinical mentor. And with that introduction, I'm going to stop sharing my screen, and I believe that will give you, Caitlin, the ability to share yours. And Caitlin, will you kick us off with your analysis of the numbers that were provided earlier and the comparison to early care? And just for anyone who joined late, our opening question was on a scale of 1 to 10, with 1 being great and 10 being awful, how are you feeling this September as compared to last September, September 2020? So now we'll have our researcher give us our results.
So our mode is around 6 or 6.5 actually. So we have some 8s, a 9, a 10, but then a lot of 5, 6, and 7s. So that can mean a lot of things to us. That could mean we're not sure. That could mean sort of neutral at this point, like maybe both were not so great. So, it's a question for us just to kind of get a landscape of the climate that we're all working within. When we've asked this question lately to early care and education providers, they have mostly said like 9.5, awful, like that the start of this school year has just been rockier for them than it was last school year. And they can point to a few reasons as to why, but I think one of them that they really uplift is being really tired. It's been a long time to be responding to a crisis. Usually crises are time limited, and this is not. So what we're going to share with you today is some lessons that we are still implementing from a time when New Jersey experienced a population level disaster where we were experiencing Superstorm Sandy in 2012, and what our response was for the workforce in the field. And as Suzanne was talking about, we recognize the critical nature of the workforce towards the health of young children and families. So we'll give you some examples here today about how we went about doing some work like this in 2012, and then how we've been addressing COVID in New Jersey now. And so as Suzanne outlined, we're looking at three layers of workforce support, to cultivate a trauma-aware and trauma-informed workforce through education and discussion, to provide relationship-based coaching, consultation, and support, and to offer opportunities for connection and reflection. And this last one, we always say, it always seems to come last in lists, but it is central to everything we're doing, that the health of the caregiver of children is as important as the health of the child because of the mutuality that happens with co-regulation and relationships. So we believe we all have the responsibility to ensure that our workforce is adequately aware and informed about the science of safety and stress, including toxic stress and trauma. So as Suzanne said, we all have different words for the, that which means trauma. We do enjoy the use of the science of safety and stress as a way of explaining this work, because it also brings in the importance of the sense of safety, which is essentially what we're all working towards. To be trauma informed is to cultivate a sense of safety. And sometimes those of us who are spending a lot of time in trauma kind of get stuck in the trauma spiral and forget, what's the reason we're talking about this? What's the reason we're being informed about trauma? It is so that we cultivate, to the extent possible, a sense of safety in ourselves and those with whom we work. In order to do that, we believe it's the responsibility of all of us to root relationship-based and reflective practice in trauma and crisis response, as well as everyday practice. So we believe relationship-based work and reflective practice are really strong trauma and crisis responses, as you'll see as to what we implemented in New Jersey, but also what we need to be doing every day anyway. We always say trauma-informed practice is good early childhood practice. There's not really a difference there. So those of us who are doing quality early childhood practice are likely already doing trauma-informed work. We also know that the workforce that centralizes relationships can ensure an efficient and effective restoration and a repair during times of crisis, which we would consider intervention, but also can promote resilience in the future, which we would consider promotion. So most of what we can think about as we think, look at different funding streams that are coming into our states, ARPA funds, et cetera, maybe what your state itself is thinking about is oftentimes they're saying short term, you need to have sustainability afterwards, time limited. And we can consider those intervention, that we are thinking about programming that might be intervening in the moment of crisis, which is right now. But then the sort of way that you make that sustainable over time is to also think about that which is intervention now is also promotion in the future. So they can really exist together. And that is a lot of what we did after Superstorm Sandy in 2012. We responded with a population level response to the multidisciplinary and multisystemic early relational health workforce, which for us includes any person who intersects with prenatal, infant, toddler, early childhood, and families. Anyone who's in that space is considered part of our early relational health workforce. This happened because previous to Superstorm Sandy, there was a group of people who knew and understood the importance of having providers be trauma informed and to have infant and early childhood mental health specifically, which is about child development and the importance of co-regulation and the importance of relationships, that those pieces were really critical to the field. So because that had happened promotionally previous to Sandy, when Sandy hit, they understood that we can use dollars, Superstorm Sandy block grant dollars that came to New Jersey to create an intervention right now, but that ultimately would end up being promotional in the future. That trauma response actually starts with a promotional mindset. So what did we do? We created a training and a formation, we say, series. And formation is a specific word that is meant to describe education technique of practice and how we are in the what we do, what we call our ways of being with. And we called this series Keeping Babies and Children in Mind. And so Jerry's going to tell you a little bit about the series.
Thanks, Caitlin. So as Superstorm Sandy occurred, and there had been prior to that, this growing movement within our state of those who understood the critical importance of relationships and infant and early childhood mental health. It reminded me of an idea that I think many of us have heard, or at least a phrase that speaks carefully to what we need to do, which is that opportunity and luck happen to those who are prepared. And when this tragedy occurred, there was a prepared group of us who really wanted to say, this tragedy, Superstorm Sandy, which hit the East Coast, was horrible. 10 of our counties of 21 counties were most severely hit initially. First 9, then 10 were declared, and then all 21 counties of our state became part of it. But at the time, a group of us convened a gathering of state, regional, and federal partners to really say, let's not forget infants and young children in what is happening, but also their caregivers and the way in which it's changed them. So we actually developed a trauma, an intensive trauma-based infant and early childhood mental health-based presentation, and offered pro bono to hundreds of people who responded to our call a chance to learn about the impact of trauma on infants and young children, the way in which it affects their stress systems and neurodevelopmental systems, and how the relationships in their lives with the buffering elements, particularly how we can help infants, toddlers, and preschoolers through the people who are in their lives and care for them. So the first thing to know is that this is not a training program. If you were thinking of it as an intensive sharing of knowledge, that certainly was part of it. But it was about mobilizing people to understand that their presence, their relationship, was by far the most critical element they needed to provide to the caregivers in the childcare community, and certainly the caregivers in private homes. And so we talk about professional formation as ways of knowing. The knowledge and concepts and science of our field is critical. Ways of doing, which are the practice elements, the tactics, the techniques, the strategies, the interventions. But the most critical is our ways of being with, and to really focus on that. So Caitlin has mentioned that, and we'll talk about it more. But the first response following the immediate gathering of partners around Superstorm Sandy was to develop a curriculum through some block grant funding that came to our state, dedicated for Superstorm Sandy response. And that's where we developed this Keeping Babies and Children in Mind curriculum. It was designed as a foundational course to raise the floor of knowledge regarding infant and early childhood mental health and the importance of relationships in their lives. And it was really designed to educate people about the impact of trauma and how relationships are fundamental to helping. So it was initially funded by that block grant money through our State Department of Children and Families. And coincidental to this, our New Jersey Department of Children and Families created a child-led task force around Superstorm Sandy to pull together all the partners. And we were present as part of that task force to emphasize, let us not forget infants, children, and their caregivers. So staff from all sectors, as Caitlin has written here, from public and private sector, early care and education, home visitation, early intervention, child care programs, child protective services or protective service caseworkers, nurse home visitors, anyone who was in reach of being with infants, toddlers, and families were invited to be part of KBCM. So the goals, as I said, was to raise the knowledge at the floor of knowledge and practice for all who work with infants, toddlers, preschoolers, and their families, to inform professionals about the impact of trauma, to focus on that interpersonal process. We have an acronym we use, which is called AGILE, A-G-I-L-E, which stands for affect, gestures, intonation, latency, meaning waiting for families and infants and children to connect, not going at our speed, going at their speed, and then engage them, AGILE. And this really was about really emphasizing the power of your presence and your caring and your being to promote this. And of course, to engage in reflective practices. While KBCM involves 7 topics and 7 sessions, 3 hours each, concurrent with these sessions were these 12-session reflective groups that would meet for anyone who was engaged in KBCM. We gathered and had scores of those groups that many of us ran statewide. So it provides core knowledge in these 5 critical themes you can see here. Early experiences matter. Development occurs through relationships. Experiences of repair build relational resilience. We actually talked so much about the notion of sometimes trauma leading to growth, post-traumatic growth. So resilience is about recovery and supporting the repair of what occurred through the trauma. Culture and context were critical for us to be honoring of and respectful of. That couldn't be more true today than it was then. It certainly is an element that we've built into our revisions, and reflection is required really for best practice. So these funds were expended in 2015. We completed that, but then KBM became a fundamental part of community development, childcare development block grants, and childcare community development block grants. I'm going to get those acronym correct, right? You all know Ccdbg, but it then became open to all 21 counties, not just the 10 most affected by Superstorm Sandy, which were primarily coastal counties. And that, in fact, has since that time become a fundamental part of our Department of Human Service funding, through which we are operating now a number of other infant and early childhood programs, including supporting, as you are, Suzanne, the quality rating improvement system in our state, the early care and education systems, but also creating a relational wellness infant and early childhood mental health system throughout our state, which is now being launched with tethers, by the way, to early intervention, to home visitation, to child protective services, and all aspects of our community that work with infants, toddlers, and preschoolers. To date, we've trained over 10,000 infant and early childhood professionals, and I would say roughly a quarter of those, maybe a little bit less, have taken all 7, which is a remarkable thing to have been able to say. So it's been well received, and for many people, regarded as somewhat of a life changer. You know, you mentioned earlier, Suzanne, that sometimes the knowledge about what trauma does, you can never minimize this, but it can often be shared in a very direct, digested way. People, you know, once people's eyes are open, they can't close them again. And once people hear the message, and so KBCM, while it's 21 hours, seems to really be a changer for people to want to learn more and to contribute more.
Yeah. Yes. And so I had seen in the chat earlier some questions around funding. So a little more specifically, the Ccdbg funds that currently and continue to fund the provision of keeping babies and children in mind are from the infant toddler set aside dollars. And yet we are permitted to be able to welcome all professionals to KBCM without cost to them. So that includes people who work outside of childcare as well, recognizing the system piece. And along with what Jerry had said, we know that when we pair coaching with education, we improve our outcomes. So as he explained, this funding also supports us to conduct infant and early childhood mental health consultation in early care and education, which in that process, we really focus on reducing reactivity and increasing responsivity. We do that through, again, the education of the science of safety and stress. So keeping babies and children in mind in this case we now use promotionally because we recognize that the providers who understand the science of safety and stress then are more likely to be more prepared when another crisis occurs. But also they start to get the concept of reflectivity and the practice of reflectivity. When COVID-19 hit, we received an increase of referrals requesting support for leadership and full program staff work because of what we believe, this use of KBCM as a promotional strategy, sort of just teaching about the importance of reflectivity as part of how we need to be with children. Their awareness was there already, and then they asked for additional support. In addition to this, we added into the state right away, April 2020, using Ccdbg funds as well as preschool development grant birth to 5 funds. We developed standalone reflective groups for the early relational health workforce, which we're calling Conversations for Connection, Comfort, and Calm. So the 3 Cs. These are 6-week groups that meet virtually for an hour. And really, there's no agenda. It's really meant to allow for the workforce to be together in relationship-based reflective support so that they can be more regulated to support children and families. So that trauma awareness that we have cultivated allows then for us to, for the workforce to recognize when they themselves could benefit from some regulation to them, to themselves, so that they're more likely to be able to be lending their calm to the children in their care.
You know, Caitlin, Alexandra, it did ask about, and you just gave some explanation, what does the reflective practice look like? And her other question was, is KBCM possibly available for other sites? And the answer to that is yes, and you can contact us and really contact Caitlin about that. But you know, the real issue, and as we did keeping babies and children in mind, and we had these reflective groups that met concurrently, as Caitlin said, the primary agenda was to normalize a couple of things. Normalize that the individuals who were working with infants, toddlers, and preschoolers and their families, normalize that they had their own emotional lives, that they had their own stories, you know, that every child, every family has the power to stir something up about your own story, whether it's your story in your personal life or if it's a story with other families. And that we have an obligation, as my old supervisor used to say, to get in cahoots with ourselves, that our best help for families is for us to be as healthy as possible. So number one, normalizing it. Number two, modeling it. I often tell the joke in reflective practice that if I'm about to have heart surgery and the surgeon, female surgeon, had a nasty divorce and I happen to look like her husband, I hope she's in supervision. And reflective practice. Now that may be like a bad joke, but the truth is we all have the power to have things stirred up in us. So normalizing that people can say, I really find it hard to work with this family or this situation. We are so careful. This never is about bashing, but about allowing a safe space. So the reflective practice, it turns out, has been such a wonderful thing. And then now that it's been really transformed into the 3 Cs and that we do regularly, I think we are finding that it's incredibly important for families and for the staff, who then in turn are helping families in a much more thoughtful way.
Mm-hmm.
Great.
And I think that's us. I think that's it.
Thank you both so much. And thank you for watching the chat and seeing some of the questions and going ahead and answering those. I have one that was posed to me that I'll answer in just a minute, but while I'm preparing to do that, we had a question come in that I think came directly to me. So I think this will be one that you all haven't seen yet. The question is just acknowledging that ACEs are often correlated with unsupportive and harmful parenting.
Mm-hmm.
So the question is, should the CDC and other health organizations and agencies be working on national parenting education campaigns akin to smoking and seatbelt campaigns? Perhaps national media. Yeah, I have a partial response to this, but I want to hear from the 3 of you, Suzanne included, if whoever has a quick thought about that.
I think it's included parent, that is an indicator of strong family engagement practices if you can provide parenting education, not only for the parents, but also for the teachers. Teachers don't learn parenting education in early childhood prep work. And it's a completely, when I went to parenting, a completely different curriculum, and so important. So I think embedding it is definitely the right thing to do. And there are systems out there that offer it. We just haven't brought it and intersected it to the early childhood field. What do you think, Caitlin? Mhm.
And, Caitlin, you go.
So, I mean, I think the CDC should recommend, humans, because parents come from somewhere, and they also come from a culture and a context. And oftentimes that culture and a context is itself toxic and traumatic. This is particularly true in our society that has the influence of systemic racism and conditions like poverty, cyclical poverty, where families are growing. So yes, it's about practices, but it's also around, are we actually honoring who families are from the beginning? Because intergenerational trauma is about interpersonal relationships, but it's also about how a family feels safe in their communities. And parenting practices are sometimes there, which might be interpersonally damaging, but are meant to actually be protective to a toxic society. So our broad, sort of taking a broad view on it, we have actually a lot of work to do. But the more aware we all are, the better off we are. The next minute someone gets aware, we're better off. So even starting small is an important piece.
If I could add to that, I think that right now, when parenting is discussed as a public policy, we both overvalue parents and undervalue parents. We overdemand that parents face everything and still do the best they can for their children, even when their own lives, their own communities, their own families have sometimes been difficult. But we undervalue them because as a country, we have the worst possible family leave policies. We don't compare to European countries. That's part of the Build Better, Back Better agenda, is to encourage more of that. So on the other hand, when we do address parenting, we tend to address it as an intellectual task. Send parents to a parenting skill program, have them go to a program. We are fond of saying and repeating, parenting is a relationship, not a skill. And when you are under stress, we tend to rely on our character more than our knowledge. Ask me. I always tell people when I teach, I'm going to be 70. My kids are in their 30s. If you looked at me when I was under stress, talking to my 9-year-olds or 8-year-olds, you would never listen to me as a parent supporter. We're all under stress. So parenting has to be relational. It has to be parent and child. It has to be working with systems, communities. And that's where I'm always afraid when things are over legislated, they tend to sort of manualize it. Just a comment about the paper you shared about the NIMH funded study in Rhode Island about identifying declines in cognitive scores during the pandemic. The paper is beautifully written and identifies all of the stressors that are involved in the pandemic. But people will read this and say, see, there's a loss of education. We have to teach those kids more. We have to give them more curriculum, more knowledge. And I think it's just what we tend to do in our society unless we understand relationships. And so if CDC does it, it has to be done in a relational way. And I think there's no question the science is behind that.
And I just want to give voice to the comment Dwana Young made that ACEs are also related to other outside of the home factors, such as
That's right. Amen.
I think
Amen.
that the structural inequities put stressors on families, and
Community bullying.
we can't identify this as a parent-only problem with a parent-only solution. Would be my addition to what everything else has been said, and that certainly raising awareness is important. And Suzanne talked about that, raising trauma awareness, and we're going to give you concrete ways to do that, leaving today's webinar. But also we need to educate everyone and get people changing their practices in every setting, every early care setting, in the home,
Amen.
Other setting, workforce development settings, when SNAP is distributed, when WIC vouchers are distributed, that, all of those things need to be done in a trauma-informed way, especially because we've had a population level traumatic event. I'm going to move us now to make sure we have some time left. I do acknowledge that there's the question to me about how to get the rescue plan money, and I'm going to address that before we close. But I do want to turn now to Jillian Adler, who's the Director of Equity Initiative at First Up, which is the NAEYC affiliate in Philadelphia, I believe that's right. Where she co-designs and leads a group of projects focused on increasing children's equitable access to high quality childcare and education by providing early childhood professionals with opportunities to engage more deeply with topics of bias, racism, equity, and justice. She's a professional development trainer, and she's a mother of a first grader and twin toddlers. And we're so very happy to have Jillian here because she has been working in the model that Suzanne spoke to earlier and that Suzanne has helped fund and lead in Philadelphia. And we'll be able to talk a little bit about that. And I want to go ahead and introduce our next speaker, because Jillian and Dr. Amy Lynch are doing work together. So they're going to talk about that work they're doing together. And then Amy is going to share with us some specific observations from her work as how she is seeing children and adults in childcare settings different now than pre-pandemic. But Amy is an associate professor at the College of Public Health and Occupational Therapy Department at Temple University and has been an occupational therapist for almost 30 years. She's the lead editor of the American Occupational Therapy Association's first ever book on trauma, Occupation and Participation, Foundations and Population Considerations for Occupational Therapy, which will be available in October. She presents regionally, nationally, and internationally on topics like trauma and early adversity, attachment, social emotional regulation, and the programs she developed for childcare settings to address difficult and challenging trauma behaviors. She's evaluating it and scaling it now. That's some of what she'll talk about today. So I will turn it over to you, Jillian, and then we'll go to Amy after that.
Great. I think, well, Amy and Jillian, welcome. I know you're coming right out of a trauma community of practice meeting together. I think we'll start with Amy, talking a little bit about YOT and trauma and what you're doing. So Amy, I'm going to turn it over to you.
Thanks. Hi, everyone. And thanks, Suzanne and Marlo. It's great to see you all. And the conversation we came into was incredibly exciting for me. And I'm sure for Jillian as well. So yeah, I'm an occupational therapist and have been working in this area for a little over 20 years with respect to, trauma and trauma specific work. And this whole talk about socio-ecological, multi-tiered at the everyday policy and practice level. I mean, that's just occupational therapy. How do we embed what we do and habits, roles, and routines at the individual family systems and organizational level? And so I just became real inspired over the years to figure out how can I truly help build capacity and build capacity at multiple levels, right? We're in a current system that really responds to trauma and in an individual manner. And yet we know that resolving issues related to trauma is multi-tiered. And so, I did lots of trainings of how to identify behaviors of trauma and how to respond to behaviors of trauma, and found that there were a lot of really great audience and people interacting. And then the next step I found was people really want to understand, well, what do I do about it? I can understand that the reason the kid is picking up a chair and throwing across the room or is diving and grabbing into somebody is because they have a sympathetic nervous system alarm response going off. They're not feeling safe, so they're acting. And I can recognize where that comes from, and I can understand that I need to be empathetic and that I need to help regulate before I can connect with them, before I can actually teach and reason. However, what do I do when they've got a chair over their head or have just, dove into another child or some other fight, flight, or freeze maladaptive response? And so, I started looking at how do we teach and how do we embed and who do we embed and teach actually hands-on technical coaching. What are principles of trauma-informed care, and what do they look like in early childhood and primary and elementary and high school levels? And so over the last couple of years have been developing and piloting and scaling programs that are very much about how do we teach kids, how do we proactively go into an environment in a trauma-informed way, and who are we doing activities with to teach what we need everybody to be doing and acting and prioritizing one another's regulation and stabilizing them in relationship and safe relationship, so that they're really ready to use their frontal cortex and really learn and grow. So in a nutshell, oh, Suzanne, you're on mute, I think.
Sorry. Could you tell us a little bit about, you're in the classroom. So any difference in what you saw last year, this year with respect to children, teachers, if you could just kind of give us a snapshot, and then we'll transition to Jillian, who actually has some good responses and we're addressing it. So if you could just share.
Yes,
a window into that.
Oh my gosh, it's a huge question. So we were out last year in the middle of the pandemic in 3 different centers and 9 different classrooms. And I thought that was hard. The level of stress and demand and the infection control and the wearing masks and shields and that the kids were struggling. And I thought, oh, this year's going to be so much better. That's what I thought going into it. And actually the reverse is true. In these early childhood centers. And Jillian and I just came from meeting with a group of early childhood folks. And it's worrisome. Children are more and more dysregulated. You know, it used to be 2 or 3 out of 18 or 20 maybe would be struggling, but it's more than 50%. Difficulty with understanding routine, difficulty staying regulated, difficulty feeling safe and connected and having no idea how to respond to the early childhood educator in the classroom as somebody who is taking the lead, let alone following the structure and routine. You know, kids are really struggling, and the educators, God bless them, have to work double time. And we're all doing it. The kids are doing it coming off of a 1.5 years, many of them home the entire time. And the educators, many of them working all the way through this, having had their own stressful, traumatic, maybe direct losses from COVID. So their tanks are empty. And I would go so far as say their tanks are empty and there's a little hole in it. So even when we refill their tanks, they're still running on empty. And yet they're running on empty with kids and classrooms whose needs are the greatest I've seen in my time in early childhood centers over the last, I've been in our ECE centers for 30 years, and it's worrisome at most. And for the kids and the staff.
Great. Somebody, if you could drop in the chat the name of your book, somebody's interested in that. Yeah, that's really exciting, Amy. I didn't realize that was happening. That was awesome. And just kind of given the time, I'm going to transition over to Jillian. Jillian, if you could just talk a little bit about, reactions to what you just came out of, because you didn't have a break. You came from that meeting to this meeting, and, some of the things that your organization is doing to respond to, these crises.
Yeah, sure. So I also want to highlight that the classrooms that Amy is referring to that she's working in this year are some of our highest performing classrooms. These are out of Star 4 centers on our state quality rating scale. These are centers with very tenured directors and centers that are struggling with high teacher turnover in general. Right now they are, of course, because everybody is, but this is a snapshot of what's happening in classrooms that were typically considered stable and successful. So you can imagine how that looks in centers where the director's only a couple of years into her work, or the teacher is, was just in a center. He just left another center last week because it was whatever. So there's a lot going on, and we have been over the past, since the beginning of COVID, actually, we have pivoted a lot of our work in collaboration with Suzanne, the United Way of Greater Philadelphia and Southern New Jersey, with to delivering trainings on trauma and the impacts of trauma and how to mitigate those impacts in classrooms. And we are at this point exploring how to downshift some of the trainings and upshift some of the wellness supports. So right now we're building a teacher well-being wellness support. We've got some funding, and we're looking for some strategies to put together to actually get people connected with the grief supports that they need to manage the loss that they've experienced during COVID, to possibly provide some respite care in their classroom so that they can get out and sit down for 20 minutes, maybe even, if we're able to be successful in thinking outside the box, maybe and get them some, like a Reiki massage or some type of a meditation guided situation. We're also starting to think creatively about how can we help them tap into the healthcare system differently? How can we get them connected with healthcare navigators so that they can meet some of their more foundational basic needs so that they can feel supported and cared for by the field, rather than in our work at First Step, we traditionally, we've always had a long history of advocating for the ECE workforce, but we also primarily do work around quality improvement, coaching and training. And we're looking at how much more can they do? How much more quality can there be other than supporting that relationship that they have with children, being able to maintain that structure and predictability, and we need to care for them first. So we're putting together ideas to figure out what can we do to care for them so that they can continue doing the best that they can and that they are for the children.
That's great. Thank you. Thank you so much. We have 6 minutes left, but that's a good example when we talked earlier in the talk about 3 recommendations around creating supports and funding for wellness for staff. This is, we're going to be keeping an eye on this to kind of see what you developed. And I think, if the city or publicly, if we were to offer these resources, people might not take them for a number of reasons, but because you're such a trusted organization in the community, if you're offering them and endorsing them, I might be more inclined to do it than if my director told me or there's a sign somewhere. So I'm just so glad, that you're stepping up. This is new territory for everybody. But there are a lot of great people that can help us figure out what to do. So thank you both. I'm going to turn it back over to Marlo.
Thank you.
Yeah.
Thanks to all of you. It was really great information for everybody. Before I share my screen to close us out and talk a little bit about next steps and some things we have to offer you to support your next steps, I just want to make sure you saw that I was chatting in the chat some links to how you can learn more about what rescue plan funds are available and where you can go to find out who the decision maker is and start lobbying them to spend money on this, on doing what we're proposing that you do. The build initiative document that I put in the chat, I highly, highly recommend because they did a beautiful job of going through and saying, here's the funds. It's for infants and toddlers. That's the focus. But here's the fund. Here's the decision maker. Here's what it can pay for. And I will just tell you that there's lots and lots of flexibility in these rescue plan dollars. And it is the time to do everything that you can do to try to get them directed to the kinds of things that you've been hearing about today. And so it is going to take advocacy because you go decision maker by decision maker. And I'm going to go ahead and share my screen because some of what our next steps are will help you know how we might be able to continue to be helpful to you. So next steps for today, we are going to provide the recording of today's webinar. We've got a CTIPP webpage on early childhood almost ready, and it will have some additional resources, including the recording of this webinar and some other tools that you can use to share with your stakeholders and decision makers that hopefully will help convince them that this is the direction they need to go. We're offering free trauma awareness trainings, and I'll talk in a second about that a little bit more, but you'll have the registration links for those in the follow-up email and the contact information for all of our presenters today and the CTIPP team. So we want to encourage you to use all of that information to share with all of your other stakeholders, have viewing parties, whatever you need to do to quickly begin to use what we're providing to you to get people on board to move in this direction. We are inviting you to attend a trauma awareness training and invite others. And I think, Suzanne, our plan was you were going to put a registration link in the chat, but I know you're having technical difficulties. So if you're not able to do that, I will just remind everybody that we're going to have them in that follow-up email. So please watch for that. But they're pre-scheduled. You see the dates and times on the screen, and as many people can attend as possible. So we set these up to help any of you who want to go deeper into understanding trauma, if this is newer information to you, but also, again, so that you can share this broadly and have a way to bring others on board. And you see we're offering 3, so you are welcome to attend the first one to see what it's like, so that as you invite other people, you can tell them, you know, a little bit about your own experience with anything is fair game. We want you to use these trainings to spark awareness and engagement in your states and your communities, your localities, even within your own child care program, if that's the role that you play in your community. And then watch your email later this fall for the toolkit. So we talked a lot today about the framework. I mentioned, and Suzanne mentioned, there's quite a bit more detail underneath the high-level slide that we showed you. We're developing a toolkit to help make it very easy to take all of that detail and walk through the steps, including, and I want to really emphasize, CTIPP, this is not something that CTIPP is, we're not funded. This was a volunteer effort, haven't been funded to do it, and we are not selling any one thing. So it's not a moneymaker for CTIPP. We will be offering a menu of the kinds of vendors and providers, like some of you heard today, who can do either all or various parts of the framework, so that you'll be equipped to be able to find your own partners that you can contract with, and will provide some sense of what it will cost. But what I will say is, relative to a lot of other things that could be funded with rescue plan dollars, this is something that you could uplift in your advocacy as something that's relatively affordable for the amount of gain that is going to come to children and adults by taking this approach. You can also request a 1-hour consultative session for a team in your state. So if you're listening today and you're thinking, oh, there's 10 other people that I need to know about this, and we need to start digging in and really getting active in advocacy, email us at earlychildhood@traumacampaign.org. We can do a limited number of these. So if you think you want to do it, be in touch right away. We're not charging for a 1-hour consultative session. We just knew that out of today, we put a lot out there today for you to think about, and that for some, it might be helpful to have a little one-on-one or small group time to kind of sift through this. But we are so passionate and eager for this work to take hold across the country as quickly as possible. But this is why we put this package of opportunities together for you. And we will, as we think of things, if you can let us know things you think you need to help you secure funding for this work, let us know, and we're on board to develop tools or other things that might be helpful. And I will also say, we've said rescue plan funding over and over in this call, but there also may be foundations who would fund this, or maybe they would, kick in money to leverage rescue plan money. There's lots of other ways to fund this. United Way clearly funded it in Philadelphia. So there's other money, and obviously in New Jersey, they were funded before the pandemic with other funds. So don't be limited in your thinking about funding. Just know that there's a real opportunity right now with rescue plan funds. And I think, I apologize, we've got a couple minutes over, so we're going to wrap up. Thank you so much to all of our speakers. Thanks to all of you for being here, and please let us know how we can partner with you going forward to help you make all of this happen in your states and communities. With that, we will wrap up, and you will hear from us via email after today. Thank you again very much.
Thanks, Suzanne. Thanks, Marla. Thanks, everyone.